Welcome, a warm welcome to you indeed. Roy Noble here, and it's a great privilege to be here as a Bevan Commissioner on an auspicious occasion. Croeso cynnes i chi gyd ar ddwrnod ni wedi casglu at ein gilydd nawr am rhywbeth arbennig I rannu gyda'n gilydd. The showcase for the Adopt and Spread program was supporting adoption as they take Bevan exemplar innovation right across Wales. I've always been intrigued with where that talent comes from. Is it innate? Are some nations better at it than others? I wondered. For instance, somebody tried to analyze the Welsh once. It was a Welshman. And he said, to measure a Welshman, you have to measure him from the neck up for a start. And Welshmen are intelligent, intellectual, and they are emotional, educated, excitable. They are cultural, they are caring, they are charismatic, vigorous and vibrant. If they could only be if they could only be humble, they would crack it, couldn't they? Mine is the same with the British. It's a mixture because every nation is a quilt of patches and the British are the same. What is a British person or an English person? Well, it's a person who jumps in a German car on the way home, he has a Turkish kebab or an Indian takeaway, sits on a Swedish settee and watches an American film on a Japanese television set. So it is spread internationally. So if you are in Wales working on these and you are Welsh, fine. If you're not Welsh, but you're in Wales, that's enough. That qualifies you to have the stamp of Wales upon you and to fly our flag, all right? So then, the Bevan exemplars have been leading the National Adopt and Spread program across Wales over the last 18 months, building on the work over the last 5 years with the Bevan exemplar innovators themselves. Now, 15 of the Bevan exemplar innovators were selected to share their innovations with a new site. Over 50 new adoption sites have taken on one of these great innovations, and over 150 people have been involved in the adoption and spread of innovative ideas and innovations across Wales. Now, this work, don't forget, has taken place during COVID-19, and the participants have had to work exceptionally hard to make an impact and to ensure that we learn from the program. There is a panel of project members here with us, and they're very welcome indeed. Participated, they did, of course, in the Adopt and Spread program, and they with guests. Now, they will be ready to answer questions, the participators. So put your questions in the chat box, and the host will make sure that your question is asked and then answered, indeed. So our thanks indeed to the exemplar innovators, because I remember Julius Caesar when he supposed to have jumped off his boat and he fell, but then he got up and he said, Veni, vidi, vici. I came, I saw, and I conquered. Perhaps these days it should be Veni, vidi, Velcro. I came, I saw, and I stuck to it. Or even better still, Veni, vidi, Visa. I came, I saw, and I got a grant for it as well. Who knows? So today, enjoy yourself, be interested, be enthralled, and be inspired. It's lovely to have your company. Diolch yn fawr iawn.
Welcome to the Bevan Commission's Adopt and Spread Showcase event. We're really pleased that you're here today to listen to our feedback and to listen to the learning that we've acquired over the last 18 months. We all know that ideas alone are not enough. They don't necessarily get adopted and spread by others, even though we think they're great ideas. And so the Bevan Commission has been really exploring this in further depths during the last 18 months or so. We've worked with 13 exemplar projects, over 50 adoption sites, and over 150 people during the last 12 months. I hasten to add, which has probably been the most difficult, treacherous, and traumatic 18 months that we've all seen. Notwithstanding that, we have seen some amazing outcomes and amazing people and who have shown their commitment and great, I guess, a great opportunity to understand what makes things work. This event today will provide further details on what helps and hinders that adoption and spread. We've got tools, we've got other support that will be part of this whole program, but it's essential that we now learn more about this in order that we can move on, not only from COVID, but move on into the future and make sure that we continue to innovate and change as we do. I'm going to hand you over to your host for today, But in the meantime, make sure you tweet, make sure you enjoy the session, and overall, make sure you make that real difference.
Hello and welcome. Good afternoon, everyone. I'm delighted to welcome you all to this exciting Adopt and Spread session where we're going to be discussing the Dementia Triage app. My name is Natalie Elliott. I'm the National Consultant Allied Health Professions Lead for Dementia in Wales. And I'd like to start by introducing you to our panel today. If we could start by going round, Clive, would you like to introduce yourself, please?
Yes, good afternoon, Prananda. My name is Clive Thomas and I'm working in Swansea Bay University Health Board, and I joined the Bevan Exemplar programme back in 2016 with the use of the Canta mobile app.
Thank you, Clive. Can I invite you in, Emma, to introduce yourself, please?
Hi there, my name is Emma and I'm the Academic and Healthcare Sales Manager at Cambridge Cognition. I've been working with Clive for a couple of years now with implementing the Cantab mobile in his practice, and he's invited me here today.
Thank you very much, Emma. Great to have you. Katie.
Good afternoon, my name is Katie Silcox and I'm an occupational therapist working within Swansea Bay Health Board, and specifically within the Cantari cluster within primary care, and I'm the adoptee of the Dementia Triage app.
Thank you, Katie. Nick.
Hiya, my name's Nick Rich. I'm a professor at Swansea School of Management and I conduct the evaluations and observe the Bevan Commission and all of their different interventions and experiments across the whole of Wales.
Thank you very much, Nick. And Ira.
Good afternoon, my name's Ira Hopkins-Jones. I'm a mental health link practitioner.
Oh, unfortunately, it looks like we may have lost Ira briefly. What we'll do is we're going to go to watch a short video about the project, and hopefully Ira is able to get back on and we can say hello to her afterwards. If you do have any questions, please keep putting those into the chat box.
Our mission is to bring primary and secondary care closer together in terms of being able to triage for dementia or early concerns about memory loss.
My vision is to provide preventative, timely and holistic OT assessment and intervention for those living within the Cantari cluster. Alongside this, also trying to improve communication and pathways between existing services.
Currently, anyone with a memory concern would see their GP first, who then decides whether to make a referral for a memory assessment. However, it isn't always clear at this point whether the problem is clinically significant or not. I've worked in memory assessment services for many years, and one of the pitfalls that the dementia diagnostic rates haven't really improved in over a decade. So one of the benefits of triaging is being able to determine whether somebody is actually experiencing a memory loss which is clinically significant or not. Our service can be accessed by anyone with a memory concern. The app is more sensitive than paper-based tests and can detect between depression and dementia. We can discuss the results and next course of action, including further in-depth assessment and possible diagnosis. We can also signpost people with no clinically significant symptoms for appropriate support elsewhere, which fits the prudent healthcare model.
So the benefits of the app is that it's really timely to use, it's paperless, and it generates a really clear evaluation sheet, which is easily uploaded to clinical systems. Furthermore, it automatically asks questions to that individual regarding their mood and their activities of daily living, which helps create a deeper understanding of that patient's situation and which pathway is best suited to them.
We've had tremendous success, and we've been able to really come up with some fantastic evidence. We've succeeded in our mission statement, which is basically to help people to get onto the pathway towards assessment and diagnosis if we are looking at a clinically significant memory impairment. But most importantly, this has helped people to get the diagnosis that they need, because having that diagnosis is their passport to care.
Fantastic. So we've now got a bit of time for discussion with our panellists. So please do take the opportunity, if you'd like to ask a question, to pop that in the chat box, and we can make sure we move on to that. But I do have a set of questions here already that have come through, which I'm going to start with. So the first question is for Clive. Clive, I wondered if you could tell us a bit about what attracted you to the Adopt and Spread programme, specifically for the Dementia Triage app work, please.
Okay, thanks, Natalie, for that question. I suppose, really, for me, as having been one of the first exemplars to have tried the project within the Bevan, I was always curious to know really what would be the next stage in that process, because in some ways we had the proof of concept in being able to use the app within our newly formed service. We felt that we demonstrated some really good results, and it was helping us to build our service within the community, and that we were doing a really essential job of being able to get to people who might not otherwise have been brought into services. And myself and a lot of other people who've been in that cohort, the second one, which was to run, were asking the question all the time, well, how can we actually bring this evidence to the wider community, because we feel quite strongly that our project is good and that other areas would benefit from buying into this. So I think it was really out of that a desire to take the project on to another level that attracted me to the Adopt and Spread programme when it was launched back in 2019.
Thank you, Clive. We have another question here that's for Emma. Emma, could you tell us a bit more about what the Cantab mobile app does, please?
Of course. So the Cantab is a sensitive touchscreen assessment of memory, mood and functional status. It's designed to identify the earliest signs of clinically relevant memory problems that are typically associated with Alzheimer's disease risk factors. The device is CE marked, TGA approved and FDA cleared. How this works is there are automated and standardized instructions that are delivered via over 20 different languages, Welsh being one of them. Your results are automatically adjusted for age, gender, and the level of education. And you're taken through a memory assessment called the CANTAB PAL, which has been used in over years of research, which has sprung out from the University of Cambridge. And then there's 2 different questionnaires that are included as well. So Katie and Clive described this quite aptly earlier in that video, which is brilliant. But to give a little bit more detail, the subject or the patient is asked, where do you see your memory in line with others of the same age? That gives the practitioner a good indication as to where that individual sees themselves, and is a good talking point for when the report comes through. They're then taken through the CANTAB PAL task and the geriatric depression scale, because the CANTAB mobile is able to differentiate between depression and dementia, and doing the GDS-15 supports a more accurate and efficient assessment to enable us to differentiate between those two. After that assessment, there can be an assessment on the activities of daily living questionnaire to see if there are lower scores within the task or the memory task. Where is it in their day-to-day life that individual is struggling? Where can that practitioner maybe suggest support elsewhere in order to aid those aspects of that individual's life, like remembering dates or going to the shop confidently on their own? This tool enables for fewer unnecessary referrals and more reassurance to the worried well. So the CANTAB mobile is able to identify those that do not have a clinically relevant impairment, allowing them to be reassured early on. The CANTAB mobile can also be assessed by nurses and support staff, so that frees up doctors' time, and the test results are automatically calculated on an instant report with an audit trail. So after 10 minutes of an assessment, that report is automatically generated, and it's down to the discretion of the practitioner whether they want to sit down with that patient there or have an internal discussion initially just to discuss those results. And within the CANTAB platform, you can either email that to a printer or you can email that to somebody with a secured password in order to access that, whether it be a doctor or a GP at a different surgery, or for an admin role to be able to print that out and put it into a medical record.
Thank you so much, Emma. That was a really helpful overview there of the app and how it works. I have some more questions here. So the next one is for Ira. And I wonder, Ira, if before I ask you the question, if we can take this chance just to say hello to you, because we lost you in the introduction. So would you be happy just to introduce yourself to start with, please?
Certainly. Sorry about that. I keep the internet connection very good. My name's Ira Hopkins-Jones. I'm a mental health link practitioner with the community resource team based in Swansea Bay University Health Board, and I cover the Neath Talbot area.
Thank you. If I could just start by asking Ira to tell us a bit more about the health technology exemplar project that you completed and what you found during that project.
Certainly. I've been using the CANTAB alongside my colleague Clive now since 2016 with the dementia support workers that we have. And recently we've had innovations within our community teams project, and we have our community resource team, our wellbeing team, which have actually purchased a number of CANTAB licenses. And we're actually going to be using the tool to find out where there's unmet need and to inform planning going forward. It's an holistic assessment, so we found that there's unmet need there, and we've been using it for quite some time now, but we are going to go forward with that. And Swansea University are interested in doing a research proposal on the back of that at the moment.
Thank you very much. We have another question that's just come in on the Q&A bar, which is asking, how do services adopt the use of this app? So we have an occupational therapist working in Wales in primary care who is interested, Christine Samuel. Emma, are you able to take this one for us? Thanks.
Yeah, of course. So typically people will individually email myself. I'm happy to put my email address within this chat so that people can pick that up. We have individuals come in through our help desk on the website. So the Cambridge Cognition own the CanTab mobile. So if you go onto the Cambridge Cognition website, you'll be able to see a nice little overview of it and a video that you can watch later on. But in a second, I can go down so that we can take individual inquiries offline.
Super, thank you very much. And another question, do you think there will ever be a time where individuals can download the app and use it themselves at home? Emma again, thank you, Emma.
Yeah, happy to answer that unless anyone wants to jump in. We wouldn't necessarily want an individual to have access to that app on their own iPad at home, namely because the results that come through are in an green, amber or red format. So if it's green, it means that you're within the normal range of somebody of your age, gender and level of education and not showing any clinically relevant impairment. If you come up as monitor, that shows that you're just on the cusp, and there's a very small percentage that are actually able to hit that monitor bar, and yeah, you're just on the cusp of maybe indicating signs of impairment, and therefore we would follow up with you in 6 months' time. And then investigate is showing that you have gone 1.5 standard deviations below the norm of the expected range for either the memory or the mood assessment, and having the word investigate pop up on a report might be quite nerve-wracking for an individual, and not understanding what to do with that information. And we're especially with individuals, what is episodic memory? Individuals who are using that app, the day-to-day person, might not understand what that means, and to be told that they're showing significant impairment without the appropriate follow-up or support around them to be able to make an indicative decision about what to do next. That's why we ask only practitioners to download this app. But it's a really good question.
Yeah, really good question. Thank you, Emma. So it hasn't been designed for that use, this app, and it's designed to be used by professionals. Thank you very much. Another question we've got is for Katie, please. Can you tell us, Katie, why did you decide to get involved in the project, and how did being part of Adopt and Spread programme affect your project?
Yes, absolutely. So my current role within primary care is that I holistically assess individuals who may be frail, who may have long or chronic conditions, and they may be frequent attendees to a GP surgery with no obvious medical issues. So therefore, I'm really well placed to be able to identify what matters to that patient, patient concerns, family member concerns, but also identify general health and wellbeing issues. So that includes cognition. So there are many aids, many assessments, many tools that can be used to further explore this and kind of validate these issues. But I was really excited by the prospect of getting involved in this project and using a really innovative but robust tool, which was already being used by Clive and the community dementia team, which had very good links with the cluster that I work in now. So I felt that I really liked the intuitive nature of the tool. So the fact that it looks at cognition, but it would automatically ask that individual about mood and activities of daily living, which as an OT is extremely important. And also the fact that it can provide really robust reassurance to that patient if they don't score a statistically significant score. So I really, really liked those aspects. But I also felt that Clive's project in itself, it's
the aims and the vision were very similar to mine, so they really aligned well. That we were looking at really holistic, really timely, and early intervention and support. And that also we could really link in with the community services and have that consistent assessment and triaging of individuals. Also, I think so we can be taking that assessment, we can be looking at completing those triages in a really, really timely manner.
Thank you very much, Katie. Emma, we have had a follow-up to a previous question that you answered, which was around people being able to use an app in their own homes. I think just following up from that, the question is about how people do self-monitor for other conditions now at home, things like blood pressure, heart rate, and just a question to you, or maybe to other members of the panel as well, as to whether we think cognition is different in that regard, and you know, what we think maybe more generally, perhaps not with this app, about people self-monitoring. Clive, I can see you've put your hand up. Thank you.
Yeah, apologies, I keep losing my connection, but I was just on the tail end of the question that Emma answered last time. And this is a question that has been raised on a number of occasions whenever we've presented our project. And I do feel quite strongly that it's what's important, and what we're not talking about here is just the technology, but also the place where it sits. So I think it was always important that where we were using Cantab, that it was framed by the right service and people with the right skills and credentials to be able to not only look at the results of the of testing using the app, but also then helping to decide what would be the next step in that process. It is, after all, a medical device, and it is intended to be used with the right clinical governance structures around it. And we felt that we were able to do that with our community team when we started back in 2016. It was always our intention that by having the right workforce around this, so for example, our dementia support workers, it would enable them to go out, have these conversations. The app itself was that adjunct that we never really intended using. It was just very lucky that we had access to it at the right time, and as a result of that, we were able to move forward in leaps and bounds. But also, speaking from experience, we can also say that there were times when it was really important that we were able to link back into not just to our service, but also into mainstream memory assessment services for further advice, and to be able to pass people on then back into the system, but with confidence. So my fear would be that if people were using this as just a means of self-monitoring, and I think there are other devices for that, that's not what this is about. This is a tool which is intended to be used within clinical systems.
Thank you. Thank you for that really thorough answer there, Clive. Thank you very much. I actually have another question for you, Clive. So the next question we've got is, can you tell us about any problems that you had to overcome as part of supporting adoption of this innovation in your health board, please?
Yeah, I think the obvious thing is, as was stated in the opening videos, is that this adopt and spread was really severely interrupted by the onset of COVID. We were literally just 2 months into the start of the spread, the scale and spread program, adopt and spread rather, when obviously the news hit us that we were going to go into lockdown. We were doubly hit by our service, because not only were we stood down because of COVID, but we were also defunded, and that was something that we did not see coming. I'm not going to go into the reasons for that, because today's session isn't really about it. But Katie also touched on the fact in her, when she was answering her question earlier, about, you know, her vision was to be able to use this tool, but critically, she would be relying on the links that were there with our service. So again, one of the problems which was unique to our service, was the fact that Katie was now demonstrating adopt and spread of a really good concept, but the very team that had implemented it had actually been decimated. So we weren't really there anymore to be able to, for her, for example, to be able to signpost back into our service so that we could maybe carry that forward. Maybe a positive for that, from at least I'm speaking for Katie, is that she, by out of necessity, therefore had to explore her own pathways, and in so doing, I think that she did actually develop good relations then directly with the memory assessment services. So that wasn't necessarily a bad thing. I suppose for us, it's just been the fact that it's been very difficult to keep this project going when we aren't even using the app anymore within our service, because we've been thoroughly depleted.
So sorry. Go on,
Sorry.
Katie.
I'm just going to add to that, just to say, Clive, you've been a fantastic support despite not being able to, really be using the app in practice. But certainly as a positive, I definitely have really gained kind of a very good working relationship with the memory services now. And that's, they're part of the virtual ward and such schemes. So despite, a negative aspect, there has been some positives.
Thank you, Katie. Thank you. It's really great to bring those positives in there as to when we're faced with these challenges, isn't it, of how we find our way around them, over them, under them, different ways of trying to still move forward. And I just wondered, personally, if I could ask you both, because we have had some interest on the Q&A from other sites that would be potentially interested in adopting the app. If you have any recommendations from your experiences for anyone who might be thinking about it.
Shall I go first? I would say that we've been very lucky to have been supported through the Bevan Commission and through what were quite challenging times. We've always had a safe space to be able to go, and what was important was that we felt that our idea was a good one, that had been endorsed from outside. I think my word of advice would be that if you're going to do this, is that you really need to be supported from within the structures where you currently sit. So that would obviously be, in most cases, the health board. We've tried to cut a furrow really where there wasn't one before, and that's been quite been described as a trailblazer before now, and I don't think that was ever meant in a positive way. It was almost, in a sense, we were going too far too fast, and perhaps we needed to hold back. But what I was saying, and I try to convey all the time, is that the Cantab app gave us the means to be able to do things that we just never actually set out to do originally. We were only ever meant to signpost, to be able to just pick up, have those early conversations with people if they were concerned about their memory. But what the app actually did was give us the means to actually do something completely different. It was actually provide an open access service where people could just come to us if they had those concerns about memory. They didn't need to go and see their GP first. That's not to say that we wouldn't have involved the GP at a later stage if the results showed that there was a need for further interim testing. But I suppose the advice would be is that if you've had these discussions and you like the idea of using Cantab, I think it's really, really important to engage with memory assessment services locally where you are. Our mission was always to help and to link back into memory assessment services and basically signpost the people who had been triaged and who we knew had a clinically significant memory impairment, so that with confidence these people then would be passed on for further in-depth testing. And I suppose if you haven't got that buy-in and you haven't got that collaboration, then, as in our case, we were basically knocking on closed doors. But I also get it that if you've got the means to be able to do this and you can see that it's been demonstrated, this is going to help you to triage not only those people who need to be seen in the services, but prudently, because that's what this is about, we also triaged out people who did not need to be seen in the service. And that's where the gain was, because we're trying to demonstrate that resources need to be done, to be used prudently, and that people who are accessing memory services now unnecessarily can be signposted elsewhere. Or, for example, as Emma said earlier on, when she was talking about what the app actually does, we correctly identified people who did not have memory issues as such or changes to cognition, but were presenting as having being low in mood. And that meant that our support workers was then able to have those conversations with GPs around perhaps treating depression as a first line of treatment before even starting to request expensive screens such as CT head scans and so on. So in answer, I just think it just needs to be part of the bigger service and not be treated as something which is totally separate.
Thank you, Clive. So really good kind of advice there for anyone thinking about doing something similar. Would anyone else like to come in to add anything to that question?
Have we lost Natalie?
Am I back? Have you got me? Yes, great.
Yeah. Okay.
So
if whilst Natalie's perhaps still trying to find a way back to us.
Okay, so I am here, thankfully, and I think we've lost Clive. So apologies for the technical glitches that we're experiencing. But just wondered if Emma or Katie would like to add anything else to Clive's answer, or if we move to the next question.
I guess I'd just like to add a little bit into the fact of making sure, again, kind of stakeholder engagement. So, for example, now that I haven't got Clive's team to make the onward referral, the consistency and the awareness of the results of the assessment means slightly less. So that's why maybe now I would choose to do a slightly alternative test that would be more meaningful to the memory services. So I guess it's looking at, again, that stakeholder engagement and the awareness of the tool.
Thank you, Katie. We have got another question come in from Jill Carson. So she's just clarifying the tool can be used to support diagnosis, but isn't sufficient on its own. Has she understood correctly? Just wondered if you can just ascertain the answer to that one for us, please. Emma, are you picking that one up?
Yeah, I'm happy to. So yeah, the CanTab Mobile is not a diagnostic tool. That requires a whole other form of medical certificate with that sort of tool. So this is more to stratify somebody and their degree of level of impairment. I also saw that you're looking at comparing it to the MMSE. So I've just got a couple of notes on that, but I can also send the PAL sensitivity and the scientific validation of this tool. But just focusing on the MMSE, the obvious difference is that one's pen and paper, one is computerized. So there's reduced human error there, not only from the patient, but also from the individual who's scoring that pen and paper, whereas the CanTab data is automated. Going into the sensitivity, looking at dementia in primary care and community population, the MMSE is moderate to high, 88% sensitivity and 86% specificity to detect dementia, whereas the CanTab Mobile is 100% sensitivity and 92% sensitivity. Specificity to mild cognitive impairment and Alzheimer's disease related dementia. Sensitivity to MCI as well is low with the MMSE, whereas again that is in the high 80% for sensitivity and specificity in differentiating adults with MCI from healthy subjects. And having a look at sensitivity to patients' age, gender and education, the NICE recommends clinicians should look into that when using the MMSE, but that is automatically adjusted for within the CanTab Mobile.
Thank you, Emma. That's really, really helpful information there.
Sorry. Just on one extra thing is that within the Cantab mobile, we do have some support documentation as to how best to follow up with an individual afterwards when they've shown signs of investigating memory and mood, or just memory. So having a look at things like, has that individual used antidepressants before? Has a history of using antidepressants? Are they on a current pharmacological intervention? If their memory is particularly low, if their memory score is the one that is low, we've got some suggestions as to how best to follow up with that patient. For example, serum vitamin B12 and folate levels, chest X-ray and ECG to determine, as determined by clinical presentation, routine hematology. So we have all of that kind of additional information that we can provide and support the outputs of the Cantab with.
Brilliant. And I notice you've put your contact email in the chat box so that people can pick that up with you. Thank you very much, Emma. I think we've got time just for one more question. And I just wanted to ask Nick about the evaluation and research side. If you could tell us a bit more about that, please.
Okay, no problem. As you've seen, we're a service under pressure before COVID hit, so unsurprisingly, being sensitive to COVID has put additional pressures on the service itself. So our evaluation shows that the efficacy of Emma's intervention is good. From a Bevan point of view and from a Welsh Government stakeholders point of view, it's a very good example of how technologists and professional healthcare providers can work together, not just on an intervention at a point and a pathway or a patient's journey, but over a greater range and a greater variety of conditions. And these conditions are particularly important for the government and for Bevan because of the high issues to do with not just the person with dementia or potentially with dementia, but also their carers. So I think we need to step back, and if you're doing an evaluation of this particular program, you'd evaluate it on the capability that Wales now has, and we have a demonstrated to prove project. There is no dominant model in this particular sector, by the way. So this is, as Clive said, very much an intervention that proves and spreads this particular type of early triage. You'd measure it on efficiency. So of course, anybody who's given an instant result and can breathe a relatively large sigh of relief because they now have a known answer to their problem, then yes, efficiency has gone up. And in terms of the effectiveness of care is now much easier to put in place at an earlier point in the particular person's journey. So if you're looking at this from an auditor's point of view or an evaluator such as myself, then yes, this particular project reinforces the prudent principles. Yes, it creates value both for the person using the service, but also for the professionals involved, because it puts more power into the hands of people earlier in the process, and it releases the value-adding time of people who currently sit later in the process that deal with more of the diagnostics and working through what happens next. So I think if you take a social return on investment perspective, it's a very good project, very, very worthwhile doing. If you take an efficiency and effectiveness and a new capability for Wales, we also have very good benefits. So overall, we just need to roll out more, understand more, but the early signs are really, really positive and very good for the people involved. So yeah, great job. Great job.
Thank you so much, Nick. Really, really good to hear the positives of the evaluation data that we have so far. Really encouraging. What we're going to do, there's going to be more time for further discussion and questions, so please do keep those coming in the Q&A and the chat box. But we're going to move to listen to a short video which will showcase some of the other projects that are part of this lunchtime learn sessions that you can sign up to. Thank you. So please do consider looking at the Bevan Commission website and maybe booking on to some of the other sessions to learn about some of the other exciting projects that are under the Bevan Commission. We're going to move on to some further Q&A now. So again, please do, if you've got anything you'd like to ask, put those in the box for us. But I'm going to start with a question that's again for Clive, please. So we've talked about some of the opportunities and challenges already, Clive. I just wondered if you could say a bit more about the context. So why triaging quickly in the community is important, and what you think, in terms of the dementia landscape as a whole, what sorts of things do we need to be thinking to look towards in the future?
Okay. Thanks, Natalie. I think for me, I've got to go back to my earlier answers in terms of where our service was sitting right at the very beginning, when we had a vision basically of developing a community-based dementia support team. So one that is basically within primary care. And I have to mention first that my background was working in memory assessment within specialist secondary services. And one of the things that I'd always been conscious of was the fact that very often we did see people perhaps who didn't have a clinical need and needed to be signposted elsewhere. They still needed some kind of response to whatever that need was, but it certainly didn't need to be within specialist memory services. So when we had the opportunity to start using an app which we knew with confidence would be able to triage out the people that didn't need to be seen, but most importantly also triage in, then what we'd hit on was something which a lot of services nationally have said has been a problem in the past. Where they have attempted to do more of the early intervention within primary care, what the literature has shown is that they did not have the access to the robust means to be able to triage. So it felt like that there was a little step that was needed before we went in and introduced interim memory testing and perhaps referral on to other services. So at the very base of all this is the fact that our dementia diagnostic rates are still low and persistently low, and you have to ask the reason for why that is. Now, I suppose what in my theory around this is that we seem to have reached capacity where secondary and specialist memory services are concerned. They do a really, really good job at assessing and diagnosing the various subtypes of dementia, but also they are inundated with more and more referrals, and all we've got is basically a bottleneck, and their capacity doesn't seem to be increasing, despite the fact that we're putting more and more resources into specialist care. So if you kind of think of this in the context of the what's been published by the World Health Organization and the World Alzheimer's Report, it's saying that we actually need to task shift some of this work out of secondary specialist services and into primary care. There is real means to be able to create more capacity around assessing and even diagnosing within primary care for those people whose need.
Oh, I think we've lost Clive mid-flow, which is a shame there. So we'll come back to Clive once he rejoins. But what I'm going to do while we're waiting for Clive to come back on is to move on to another question that we've got that's come through, which is open to any of our panelists. I wondered who would you say are the main stakeholders who would need to engage in a project like this, please?
So I guess from my experience of using the app and being within this project is GPs is a massive, important stakeholder, as they need to understand the project and the app and be able to, with confidence, understand the information and agree with the further outcomes. So I'd say GPs are a massive stakeholder, and also secondary services, so secondary dementia and community services.
Thank you. Would anybody else like to add any other key stakeholders to that?
No, I think Katie covered that quite well. I think we've got CanTab being used currently in pharmacies as well to try and lessen the burden within a GP clinic. Again, those within the GP clinic don't have to be doctors or certified nurses per se to actually administer the tools. So with that secondary care, that you're mitigating any limitations in that way. I mean, it's being used in private and public hospitals across the US and the UK. Clive.
Hello, I'm back again. I don't know how much of my answer you heard, but if I need to repeat anything, I'm glad to.
I think we got maybe most of what you were trying to say there, Clive, and we're just talking about key stakeholders now involved in a project like this. And Katie has mentioned GPs. I know you previously talked about memory assessment services, and I know that we have Katie as an allied health profession, occupational therapist. You're a nurse by background, Clive. As is Ira. I just wondered if you wanted to add to any other kind of key stakeholders.
I did, and it's already been mentioned, but basically we demonstrated that that our service was open access, and we expected, I suppose, a lot of members of the general public to approach us. We actually found, in reality, when we looked at the data, that the biggest group of referrers to our service were GPs. And I was curious as to why that was, when in fact GPs have always been able to refer anybody with a memory concern to memory clinics or memory assessment services. And the feedback that we had was that the GPs just liked the informality and the ability to just signpost. They didn't have to do anything other than this at this particular time. There was no need at this stage to request any further investigations. So what they liked was the fact that, having referred to our service, having then had the feedback from us as to whether this was clinically significant or not, they would then wait for our clinical guidance in terms of requesting a CT head scan, blood investigations, and so on. So I suppose, for me, in terms of who were our biggest investors, it was the GPs. It, as Emma rightly said right at the very beginning, it saved them time in consultation. But quite importantly, GPs were flagging up the fact that they do not feel comfortable assessing people's memory during consultation appointments. They felt it was too rushed. Obviously, this was the time when, pre-COVID, when people were able to book appointments and face-to-face. But they also realized that this was actually a much more person-centered way of being able to approach this problem. And they recognized that they would prefer and feel more comfortable delegating this to a team of individuals who are skilled at doing this, but also with the robust tool and means to be able to do that.
I wonder if I could ask you, Clive and Katie, on the kind of stakeholder point of view, thinking about people's experience of using your service. So people who you may be diagnosed with dementia, people who you might have reassured or signposted, for monitoring. Just wondered what kind of response you had there and how it was received by the population.
I don't know. Does Katie want to go answer that?
Yeah, sure. So, yes, got really good feedback from patients themselves who completed the tool. They found it was quite less clinical, so to speak. It often was being completed within their own homes, so they felt more comfortable. It was a bit more patient-led. So yeah, they really liked the tool. They thought it was quite novel. They liked the fact that it was electronic. And they were aware that, whatever the score, that there would be a follow-up of some type. So whether that would be further investigations, whether that would be reassurance, and then investigating kind of, the rest of the situation to find out why they're feeling that way. So yes, really positive feedback. But also from GPs, positive feedback that they really liked the really clear evaluation sheet, that, you know, it was colour coded. It was just very clear, and they liked it.
Thank you. Would anybody else like to add anything to that answer?
I think people did appreciate having their assessments in their own home as well. That's very important. I think rather than dragging someone off to a memory clinic, I think, you know, it gave the person they were more relaxed and doing it in their own home environment. And also some of the questions that they were being asked. When you're asked it on a computer, you can just read it, and especially about your mood, you don't want to tell your nearest and dearest exactly how you're feeling sometimes, because you want to spare their feelings. But, you know, you've got a more honest answer, I think, especially with the mood assessment on the Cantab mobile.
Thank you. I just wondered, did you have any people that found it difficult to interact with, that it didn't suit? Right.
Again, if I could maybe give some feedback, and again, I would reiterate, because this particular tool was used by the dementia support workers, it's not really my experience that I'm able to draw on, but certainly their experiences and how they fed that back to me. And I think sometimes it was a matter of them being able to use, you know, be discerning as to who might be the most appropriate, you know, fit for this particular means to assessing. Not everybody liked it, but surprisingly, a lot of people did. And again, you know, we have to be really aware of perhaps some of the embedded prejudices that anything technical doesn't fit with the older demographic. And what we actually found in practice was that many people quite enjoyed the challenge of that. For them, I suppose it was the right means, but that's not to say that on occasions there were people who just didn't want to know about it, and that's okay. It's not absolutely critical, and it wasn't absolutely necessary to force that in order to get an outcome. There are other ways, and we can resort to using paper and pen and some of the more established, you know, the other established cognitive tests which are out there, which do something quite differently, I must add. So yeah, I suppose in a way, not for everybody, but surprisingly, a lot of people did take to this.
Thank you. So what you're saying is it's an option in your toolkit, that it may not be for everyone, but for a lot of people, and sometimes people that you maybe wouldn't have expected to get the benefit from. Yeah. Really engaged with it well. Thank you. So just bring in another question, which is open to everyone on the panel. Wondered if you could say, if you were talking to our senior leaders in health and social care today about this type of innovation, what would you want to say to them about how it could be adopted, for example? Nick, thank you.
Looking on an all Wales perspective, I think you'll find that every single health board now has innovation leads, and they are, if you like, at the centre of a web of technology and dissemination. So there's been a big investment in innovation and people in positions across Wales to disseminate this type of innovative projects. So I think the investment's there, the infrastructure's there. I think we sometimes have to condition, as Clive said, certain people to working in new ways and having less technophobia and seeing the value in it, and potentially seeing how much of my working week this will give me back, so I can concentrate on other more demanding pressures on my time. So I think if we could, it would be nice to show people this is what it means for your quality of working life, and virtually everybody in our service is employed for their diagnostic and thinking capability. Everybody. So the more time we give back, the more we will benefit. So I think the infrastructure is there for promoting things at the government level and at the health board level. I think that potentially we now need to show and demonstrate the social return on investment that will really get people's antennae up and twitching.
Thank you. So it's gathering that further evidence to add to what we already have, to share with those key people. Thank you, Nick. Does anyone want to add anything else to that? Clive, thank you.
I would only add, really, as I mentioned earlier, I mean, we have been really well supported by the Bevan, and it's been really important where I think you're challenging the status quo and the conventional ways of doing things around here, as they say. That's a very challenging place to be in. Trying to do any kind of change within the health system is quite isolating at times, and it's really important that people within organizations are able to reach out and to give their support and encouragement, especially when you come across difficulties, because otherwise, and I can only speak from my own experience, you're having to deal with all of these challenges very much on your own. And it's your name that becomes sort of associated with this new innovation. And I don't think it is ever about the individual. This is about a service. This is about ultimately serving the public. That is what we do. And if we have come across a really good idea that works and is prudent and helps people to connect to the right people at the right time, we have a duty to shout about it and say, look, we've demonstrated it and it's working really well. How is it going to fit into the bigger picture? And I feel that if that's just going to fall on deaf ears, and if people are actively going to work against you, then, you know, we've got a real issue here that needs to be addressed. And you cannot do it from the bottom. It has to go to the highest possible level within the health board, where they can say, well, can we help you to become unstuck? Who is it that needs to speak to whoever in order to get us over this issue? And I can say, hand on heart, I think I've tried absolutely every single avenue of communication, and just to find that has been closed, it's been beyond disappointing. It just leaves you with a feeling of, well, why bother if that's the case? But it's only because of adopt and spread and knowing the connections with academia, with industry, that this is the way forward. Technology is not always going to give us the answers, but it's certainly going to help us to do our jobs better.
Thank you, Clive. It's really important in building that network and getting that right support, and Bevan Commission is a great support for innovators, and bringing new connections with other people across the patch. Fantastic. I just have another question that's come in from the audience, which is a practical question around whether it's possible to skip questions within the app, and whether you have to complete it all in one go, or whether it's possible to stage it over a number of sessions if needed. Emma, thank you.
Oh yeah, so yes, within the CAN tab you can switch on and off certain elements of the platform. So you've got the CAN tab PAL, which is the cognitive task with memory. You've got the GDS questionnaire and the functional activities of daily living questionnaire. If, let's say, for example, you've already done an assessment outside of CAN tab looking at functional activities of daily living, then one of those can be switched off. But at the same time, it's only a 10-minute assessment, so you can't do it over several sessions. You would do the one test administration at that one time point, for two reasons. One, the way that you switch on and off those questionnaires, there's a reason behind you switching them off. So you would only really assess them the once, but the main reason is that the normative data in the back end of the software is comparing against those who have only done the assessment once themselves. So if you were to do this over numerous points, you've just got to take that into consideration when looking at the data. The only time we would recommend a repeated visit is if somebody shows up or flags up as monitor, and that can be done 6 to 12 months after the original assessment. The functional activities daily living questionnaire only appears if one's memory score is particularly low anyway. So if somebody's memory score was in line with their general cognitive aging, then it's just the DGS that you would do afterwards. But if they're showing clinically relevant impairment within the PAL task, that's when the functional activities daily living questionnaire pops up.
Thank you very much, Emma. I think we've got time just for one more question. If we can answer this one briefly, that would be great, panel. I just wanted to ask you, if you were speaking to developers of apps or technologies aimed at supporting triage in the community for dementia, what would you say to them, and how can they support adoption better, please? Who would like to take this one for us?
So I guess in terms of kind of development, an area that I would really like to see in terms of within an app, and it's been mentioned, one of the questions is just the use of informal carers and being able to input their opinion and their experiences, I think would be really valuable. So that would be a certain development for the future.
Thank you, Katie. I can see, Clive, you've just come back in. If you wanted to give any messages to any app developers working with people living with dementia, is there anything you'd like to say on that briefly?
I suppose really with regards to an earlier question that we were asked around self-assessment, and I suppose really I answered it in saying earlier that this is a medical device and sits very much within an assessment framework, but interestingly, if you do look generally to see what technology is out there, there isn't really a great deal of competition. And obviously competition is good in the sense that perhaps if you're looking at what products do and value for money, how accessible they are to services, then the more apps that there are out there, the better. But in terms of confidence with what Cantab is doing, it's in a field of its own. It's quite separate. But that's not to say that perhaps there may be something out there that people could use in order to perhaps assess any concerns that they might have. On the other hand, I'm also kind of aware of the fact that sometimes people are quite anxious about a problem concerning their memory, and we don't really want to encourage or make that problem worse by I suppose encouraging people to go away and test ad nauseum. My personal feeling is that this is probably best done within a clinical structure. And that's not to say that there is an awful lot of technology out there as well. We've got links to a local company who have been looking at devices that people can wear. So, for example, if people are worried about somebody becoming lost in the community, at least there's a safety mechanism that they can fall back on. So there are lots and lots of ways of implementing technology. Not so sure really that, or I certainly in my experience haven't seen anything like Cantab out there.
Thank you very much. It's been such an interesting session and discussion. The time has flown. I've really enjoyed hearing more about your project and your ideas of how this can, move forward and be adopted in other areas. So I just want to say final thank you to all our panelists for sharing their experiences. And we're going to leave you with another short video. Thank you for joining us this afternoon.